Good morning.
Good morning.
Let's just give one more minute to those who are logging in, and then we're going to start with Luisa presenting the case that we started last week, and then we're going to continue. So, Luisa, if you can, just briefly present again the clinical symptoms and history of the patient, and the preoperative exams, so we can go to the surgical video and then discuss the nuances, and then we're going to go to the post-op. And that's going to follow them by Dr. Vargas and the presentation that we couldn't finish last week.
Perfect. If you want, I can start sharing the screen.
Yeah, absolutely.
Yeah, you're already co-host, Luisa.
Okay. Everyone can see my screen?
Yes.
Okay. So, as a quick recap, our case is a 57 years old man with 2 years of progressive loss of vision in his right eye. So, after the ophthalmological examination, we start to raise the suspicion of something intracranially. So, in some of the images, I'm gonna quickly skip on the video and just going straight to some of these ones. So it was this increased the suspicion for a meningioma. However, in the T2 weighted images, it has some atypical features. That is something to keep at the back of my mind, in our mind. So also we can see in the images how it was the optic nerve involved as well the ICA. So with this in mind, we just can go back to the video. So we started the video.
Just a second, Luisa.
Yes.
Just before we go into the video, if we can go back to that, the surgical steps that you had. I think it's the previous slide. Yeah.
Right.
So as Luisa said, this is a patient that presented with right-sided progressive visual decline, and that came to us with a vision status that was 20 to 400, if I remember correctly. Otherwise, he was completely intact. Very nice young man. And he, in the preoperative scan, we had the image suggestive of an extraaxial tumor, a meningioma, with invasion into the right optic canal and arising mostly from the medial sphenoid wing / clinoid. Therefore, when we look at those images, we have, of course, to come up with a plan and a strategy for treatment. And in that regard, we always think about, well, conservative treatment versus surgery versus radiation. Those are the basically three options we have for meningiomas at this point. And in this size of a lesion, young patient with progressive symptoms, certainly surgical resection is the optimal and primary option. So that was the option for him, surgery. The next step is how to do surgery in a case like this. Can you go back to the MRI? I'm gonna just quickly go through those steps. So not gonna, that's fine enough. So this patient once again had a lesion arising from the clinoid, and as you see attached to the lateral wall of the cavernous sinus and to the clinoid itself, with extension into the right optic canal with compression of the optic nerve in the transition between this external segment of the optic nerve and intracanalicular segment of the optic nerve. When we see tumors like this, we have to think about different techniques to remove this tumor. And it is our impression that the best option is to combine a lot of extradural work with an intradural dissection and external manipulation. So the first step is a wide craniotomy that allows us exposure to the base of the skull And that was a pretemporal approach that basically is an extended trional craniotomy, getting to the tip of the temporal pole and to the sphenoid wing and clinoid as well. After that, we get mobilization of the basically the low temporal lobe dura with a partial peeling and a clinoidectomy. And that's also we can expose the optic canal, unroof the optic canal, and then open the optic canal, and all of this extradurally. So we haven't even opened the dura yet. After we decompress the optic canal, it's only then that we're going to go ahead and open the dura. In this case, mobilize the M2, M3 branches, and then start the debulking. So before debulking with a frontal temporal exposure here, we can get the optic nerve decompressed. We can see the supraclinoidal ICA, the optic nerve, and in the back part of the tumor, the M2, M3 after opening the Sylvian fissure. That gives us in control all the most important neurovascular structures so we can safely debulk this tumor very aggressively. Additional to the fact that allows us to further devascularize the tumor in the beginning of the approach, even before touching this tumor. And then after we do that, you're going to see that we can safely resect this tumor. So maybe with those considerations in mind, let's see if we could follow those steps, which are always the steps as we like to say, it's almost like a cookbook. We have to go one step at a time and always following those steps that we have always to have them in mind, even before going to surgery. So surgery must always be a repetition of what we have already planned beforehand. So let's see what the video shows.
Great, thank you very much. So in the video, we already passed some of the steps first.
No, you can show the entire video, Luis.
Okay, perfect.
So basically, skin incision, the skin flap was mobilized forward. And then after that, we saw the frontozygomatic suture. Then you see preserving superior temporal cuff. We're going to mobilize the temporalis muscle downward, which is the advantage of doing the interfascial dissection for a case like this. After that, the typical frontotemporal craniotomy is initiated here. And then we're going to go ahead and mobilize the cranial flap. And after that, drill the temporal pole and mobilize with a partial peeling of the middle fossa. After that, the hyperostotic sphenoid ridge is drilled, and then we have to remove the clinoid. So now with a 3 millimeters drill, we can start peeling and drilling. So we always disconnect the 3 attachments. Can you stop the video there?
Sure. I'm so sorry. Yes.
Nice, you can stop right there.
Okay.
So once again, just a technical nuance for extradural, in fact, either extradural or intradural clinoidectomies, but what you see here is an extradural clinoidectomy. After this sphenoid ridge is drilled, you have almost like completely separated the most lateral attachment of the clinoid, which is going to be the sphenoid ridge. And then you have 2 additional attachment points. One, it's going to be the planum sphenoidale, and the other one will be the optic strut. So after drilling the sphenoid ridge, you're going to drill the planum sphenoidale. And then after that, you're going to go and you're going to see in the video next that we're going to have to drill the optic strut, which is located right below the optic canal. So at least in my opinion, the good movement is sphenoid ridge, planum, and then you go laterally, expose the lateral wall of the optic canal, and then drill inferior the optic canal. That's okay. After the drilling is done, you can play it, Luis, it's fine. After the drilling of the clinoid is done, you have to detach the clinoid from the interclinoidal ligament and anterior and posterior petroclinoid ligaments, and then you can mobilize the clinoid as you see in the video. And then you see here that now we're going to the roof of the optic canal, and with a feather blade, we can go ahead and open that roof so we can basically unroof the optic canal, cutting the falciform ligament.
Something in my computer is making me jumping out of the video. And so
No worries.
it's right here.
And this movement of the clinoid, as we had discussed briefly last week, you should always keep in mind what you have below the clinoid, which is going to be the optic nerve that is actually going to be medial to the clinoid, and the clinoid segment of the ICA that is going to be interior, and then the oculomotor nerve that's going to be right inferior and lateral. And that's why you pull the clinoid from bottom to the top and from lateral to medial, so you can mobilize it away from those structures. And here you see that after the, can you stop the video there?
Yes, sir.
A bit forward. Yes, stop there. Yes, and then what you see there is that once we have opened the falciform ligament, we basically see the meningioma being peeled away from the optic nerve. And then we see the carotid in the inferior aspect of that. And then you can just play the video, Luis, it's fine. Mm-hmm. After that, the door is open. Yeah, you can play. So usual dura opening, dissection of the sylvian fissure and exposure of the M2, you see the MCA bifurcation. Then you have to separate the branches that are surrounded by the tumor. And you see here with microsurgical dissection that in this case was easily done because the vessels were relatively superficial. So once we mobilized those M2 branches, we could just go ahead and, I'm sorry, M3 branches, we could go ahead and debulk. After large debulking is done, we went back to the base of the tumor. What you see there is the right ICA and the optic nerve. Now we're using a Rotem 6 dissector to mobilize the tumor away from the optic nerve. And then we're gonna get all the way to the right A1. Which you start to see there. You can just play loose, it's fine, no worries. And after we mobilize that from the right A1, right optic nerve, right supraclinoidal ICA, we could just mobilize the tumor. And then you see that cleaning around the carotid, and you see the optic nerve cleaning around the optic in the carotid, and you see the A1 running from the carotid to above the optic nerve, and here further opening the optic canal to further maximize the resection of whatever part of the tumor that is left. After that, just showing the final status, hemostasis, and the reconstruction with some fibrin glue, the substitutes, and then the usual closure.
Thank you very much, JP. It's always good to know every single step, and that's the most important thing about this case, or at least the most fascinating one. Well, now with the pathology, I would love to ask Dr. Gentov, are you in the meeting?
Yes, I'm
Yes.
here. As you can see, we have a very classic meningioma here. It is a little bit more fibrous than typical, but not really what we call a fibrous type meningioma. But in between the different parts of meningioma, you can see there's something that has a different consistency, and that's brain. So this tumor was invading brain. So although its mitotic activity was not really high, it's still considered an atypical meningioma because of the brain invasion, which means it will behave more aggressively.
Thank you, Dr. Gentov. So the diagnosis?
Yes, atypical meningioma with brain invasion, so it's a grade 2.
Thank you very much, Dr. Gentov. So in the postoperative images, you can see a complete resection with no residual, just the postoperative changes, the expected changes. Dr. Agarwal, are you in the meeting?
Yes, I am here, Luisa.
Would you like to comment?
Yeah, so basically this is an expected post-op image, and the things we are looking for in a similar case is whether we see any residual enhancement or not. And right now what we are seeing is a T2 axial image. I don't know if you have some post-contrast images as well, Luisa. Do you?
Yes. No, sir. I don't have it.
Okay, so that's the main thing we're looking for. Of course, the presence of any parenchymal hemorrhage, any big territorial infarct, and finally, if there is any residual component. And the idea is that if you have any enhancement within the 24 hours, any solid enhancement, then it's not granulation tissue, it is residual tumor, because granulation tissue takes some time to enhance. So you don't expect scar tissue or granulation tissue to enhance within 24 hours. So anything which is enhancing within the first post-op day is likely residual tumor.
Thank you very much.
I just want to comment. Can you go back to that
Yes,
teacher?
sir.
Yeah, just there. It's actually about a surgical point rather than the imaging point. But if you look at the rightmost lateral aspect of the right part of the frontal sinus, you're going to see that there is a hypointense, isointense tissue there. Yeah, that is basically that we didn't show in the video, but we did have a small opening of the frontal sinus there. And remember that we preserved the pericranial, the vascularized pericranial flap in the beginning of the approach. So what we did in the reconstruction is basically we just covered that area with the pericranial flap and secure that, attach it to the dura in the reconstruction in order to occlude that part of the frontal sinus and separate it from the intracranial space. So one more reason or advantage of preserving that pericranial flap vascularized to minimize issues with the frontal sinus. If we had had a more significant opening in the frontal sinus, certainly we would need to do a more extensive cranialization with drilling of the frontal sinus and so, but was a quite minimal one, so we just closed it with the pericranial flap.
Very much. So in the postoperative course, it was completely expected changes, no complications. The only change was related with the patient's insulin medication. But in the postoperative day 10, when the patient was at home, the patient is highly allergic to dogs and he was exposed. So after many Valsalva move, the patient had to go back to the ER because a new local swelling over the craniotomy area. Possible, it was diagnosed as a pseudo meningocele produced precisely because of the Valsalva move and was managed with acetazolamide without any other inconvenience.
A funny detail about that, the patient started coughing because he had his daughter visiting with a dog. So the treatment for that was to get rid of the dog and the daughter and the medication. The patient was happy to get rid of the daughter, was not happy to get rid of her dog. So that was the difficult part, but he got better afterwards.
Yeah, and a lot of antihistaminics afterwards. I'm seeing a hand raised right now. Neri Lamothe. Sorry if I pronounced it well.
Yes, Lamont, I wanted to ask you, could you go back to the MRI images? To the
yes,
first?
of course. Of course. Which one do you prefer?
First, I'm trying to look for the dural tail and the CSF cleft, which distinguish the extraction mass, because you said it was a meningioma, right?
Yeah, that was it. So where you want this one, the pre-op?
Yes. the first one before the operation. Can you show the CSF cleft?
Okay, probably for that will be better to
I think,
have a
no,
bit.
actually, Luisa, you can go back to that image there.
Mhm.
So you see the arrow that's pointing the image in the middle, or the T2 weighted image. So in that aspect, you see the tumor as hypointense, and you see that hyperintense ring around the tumor. So in this case, you have that demarcation, which not all you can see meningiomas, because sometimes it's also tight and infiltrative. But in this case, you see in the image what some would call the CSF cleft or the Cicero cleft, which is one more signal for the meningioma. Let me just suggest one point, just because we're going to have the next presentation as well. Let's go all the way to the end of the talk, and then we can open for questions and comments. I think it will be easier to discuss them maybe at the end, if everybody's okay with that.
Gonna
Thank
go
you very
back.
much.
You're welcome. So finally, in the follow-up with neurosurgery, the patient was doing very well clinically. Actually, the improvement was amazing, and the patient was very happy about that. The plan was in 3 months, to do a follow-up with the MRI and discuss about other alternatives as a radiotherapy or just continuing the follow-ups. Is pending the upcoming follow-up with the ophthalmology service, of course. So I don't know. And Dr. Q specifically asked for these questions. I would love to, now that we're open to questions, like what is next in these cases? What is the follow therapy, or what are your ideas or your what you would like to do, basically? So I will, I don't know if it's Dr. Trifiletti is in the meeting right now. Dr. Trifiletti? Now I would love to open the question for everyone.
Yeah, I want in that same well, just a comment about this specific case, and then we can go more general. We did have that discussion on tumor board. So this is a grade 2 meningioma in a relatively young patient who is doing clinically well, recovered. We according to our intraoperative assessment in the post-op scan, we have a gross total resection with drilling of the surrounding bone. So I would classify this at least as a Simpson 2, if not a Simpson 1. And he's doing clinically well. So because of that, we decided to favor conservative rather than to go ahead with adjuvant radiation right now. But we have to keep in mind that there are ongoing studies assessing exactly that question of upfront radiation versus delayed radiation for grade 2 meningiomas, which is still a matter of debate. Even with the results of the clinical trials, there's a lot of concern, not concern, but questioning of the designs of some of the clinical trials about that. We need to keep in mind. The second point that I think is interesting to discuss is, there are new clinical trials that are looking at the potential role of some actually, chemotherapy as target therapy for some tumors with specific signatures. And some of those trials even include cases like this, first-time surgery with no recurrence. And so that's something that may be coming in the next 5 years or so. And finally, a point for conversation with Dr. Gentoff. When the inclusion of brain invasion was done in the WHO classification, in my opinion, there was some sort of controversy about doing that. And I hear that may be changing in the near future as well. And I wonder, what is your perspective about that specific item for classifications of meningiomas, and how do you see that in the consideration of the other aspects that we use to classify meningiomas as a grade 2?
So there are two different really types of brain invasion, and it's similar to invasion in other parts of the body. There's sort of a pushing invasion, and then there's one that's more infiltrative. The ones that are more pushing, and this had more of that feature when you looked at the whole thing, it tends to do better than the ones that have a more infiltrative, is my understanding. I haven't read the specific studies on that, but I have been told that by a colleague that back quite a ways back when they used to look at that more. I think that may be a consideration going forward, especially in one that's not as mitotically active. But I think the concern with this is that when you have brain invasion, if there's recurrence, is that, that the entire tumor didn't get removed because some may have percolated beyond. But I'm not sure if it will change in upcoming classifications, but I have heard some discussion amongst some peers about this.
Thank you. Yeah, that was our impression because, of course, our impression is surgery. It's absolutely sometimes very different from what we can see under the microscope in pathology. But this was those types of cases that, intraoperatively looked like a classic meningioma with well-defined edges and borders. Of course, sometimes pathology is definitely different from that. But that was the other point that made us, okay, let's, good resection, good outcome, clinically speaking. Let's give him at least 3 months and see what's going to happen next rather than going with upfront radiation in this case. But I fully agree with your points. I'd like to open for other comments and questions as well, please, everybody. If anybody has any points they'd like to bring, feel free to do so. Well, if not, I'd like to thank Luis again, Dr. Gentoff, Dr. Agarwal, everybody that participated in this case. These patients continue to be followed, and oh, nice. Go ahead,
Yeah,
Luis.
we have a little bit more, some pearls for this presentation. So first of all, there are 2 great articles for this, precisely the anatomy, for the procedure itself, and once again, talking about the steps and how to do some research when we have these cases. So the first one is an article by Dr. Oliveira, that the pretemporal approach, that's the approach that was used here, from above and below, the microsurgical anatomy of endoscopic, endonasal, and transcranial microsurgical approaches to the paracellular region. There's a lot of the anatomy that we just saw. Also a classic of MEFT meningiomas. There's a must in meningiomas, and Video Atlas of Neurosurgery, a book from where I took this pearl, the benefits of the extradural clinoidectomy, just to also the opening of the falciform ligament and then the optic strut. So this is very important precisely for the decompression of the optic nerve. And says the big pearl. Also, a very little thing that I just saw while I was reading all these things is samoma comes from the Greek meaning sand, even though it wasn't what we saw specifically. It's just something related with the meningioma. So it's the first thing that we think about every time we talk about meningioma. So it was just a quick tip. And at the end, thank you. And I would love to leave this quote because, yeah, this is my first presentation. This couldn't be possible without a lot of help and great mentors. So thank you very much, everyone. Anybody has a question?
I'd just like to congratulate you, Luisa. Very well done, especially being your first time presenting here. And Dr. Quinones himself is traveling right now to WNS in Philadelphia, but I know he's very proud of your work and he's very thankful to have your collaboration here. So thank you very much. And as Dr. Quinones always says, it's a great teamwork that is necessary. Thanks for leading this teamwork for this presentation and collaboration.